Okay. Hello, everybody. First of all, I would like to thank the Armenian American Medical Society for having me today to share with you the recent updates in rheumatology. My name is Lilit Pilossyan. I am a rheumatologist in private practice in Van Nuys, California. And for the purpose of today's talk, I will be going over 4 different patient cases and highlighting recent updates and guidelines that have been published in rheumatology. And this presentation is going to be equivalent to 1 CME credit. So yeah, let's get right into it. What is new in rheumatology? I have no disclosures or conflicts of interest in this presentation. So we're going to start off with case number 1. We have a 60-year-old male history of diabetes and hypertension, presenting with 3-day history of right first MTP pain, swelling, and redness. His symptoms initially started as tingling in the area and then quickly progressed to redness, swelling, and severe pain. He has been taking Tylenol as needed for pain, which does not really help him. He's unable to bear weight on his foot. He is unable to sleep because of any movement worsens his pain. He states that this has happened about 2 more times earlier this year, but previous occurrences lasted about a week or so and then resolved on its own. This is his medical history, nothing really remarkable. He does drink beer about 2 to 3 times a week after work. He does have a maternal grandfather with history of gout. His exam was most relevant, consistent with right first MTP, erythema, warmth, and swelling. He had tenderness to palpation, even with light touch, limited range of motion due to pain. He had no nodules or no tophi. This is a classic picture of what his foot looked like, and this in medical terms would be described as podagra, which is right first MTP pain, right first MTP swelling. Imaging, X-ray of his foot 1 year ago showed that he has unremarkable exam of the right foot. And labs from 2 weeks prior shows that he does have a creatinine of 1.4, which is equivalent to CKD stage 3A. His serum uric acid has never been checked. So here we have the 2020 American College of Rheumatology guidelines for management of gout. Gout is a long history in the past, and it was referred to as rich man's disease, or the disease of the kings, because usually with gout, there is a diet associated with it that can trigger its flares. So, for the treatment of gout flares, I'm going to be going over the guidelines with this patient's case, which each, step of the way. So we're going to go through it all together. So for the treatment of gout, we generally have 4 different options to treat these patients. And the last one here, the IL-1 inhibitors, I wrote it in small letters because we really don't use them too much. It's only for really refractory cases, which thankfully we don't see too often. So usually, if it's 1 or 2 joints involved, we recommend an intra-articular glucocorticoid injection. They're really a relatively low risk, they're effective, and they don't have much side effects related to it, and are really effective in treating the acute gout flare. This is good if it's feasible, because there are instances where either the patient refuses an injection, or the providing practitioner doesn't feel comfortable with injecting the joint involved, or there's times when there's a concern for septic arthritis, and oral medications might be a better option at that time. So if we can inject, we inject. If that's not possible, then we have oral agents that are really effective as well in treating gout. We have colchicine, non-steroidal anti-inflammatory drugs, your NSAIDs, and also systemic steroids, which could be given oral, IM, or IV, or intra-articular, as we saw with the first option. If everything refractory, we can go ahead and give IL-1 inhibitors like anakinra and now recently approved canakinumab. And just to mention, colchicine, NSAIDs, and systemic steroids, they're all equally effective. So it all depends on the patient, their age, their comorbidities, and trying to decide which medication to use. And also one more thing to kind of point out with the treatment of gout flares, it's really important to treat at the initial, like as soon as possible. So I always tell my patients, if you feel like it's coming, you know what gout feels like, you should start as soon as possible. Because I consider gout kind of like a fire happening in a house. So let's say if we have, the fire starting on the stove top, we can use the fire extinguisher, get rid of it, and within minutes, hopefully the fire's contained. Versus if we let that fire kind of brew and go and spread, it can to the whole house, then we would need firefighters, water hoses, and much longer time to kind of calm it down. So similar to gout, as soon as the symptom onset, once we take care of it with these medications, the shorter the course of the disease and the less the patient will likely suffer. So with colchicine, I do love colchicine. We use it a lot. In the past, again, we used to use higher doses. I think 1 tablet every hour until the patient developed GI symptoms such as diarrhea, abdominal pain, cramping. So that's kind of fallen out of favor. So what we use right now is a much lower dose, but it's equally effective in treating the gout flare. So we usually do 1.2 milligrams at once, followed by 0.6 milligrams an hour later, and that's it for the day. And then the subsequent days, we do 0.6 milligrams BID until the flare resolves. Colchicine is a relatively safe medication. The only downside is if high levels accumulate in the body for the reasons here listed below, we do need a modified dosing, and primarily because colchicine in high doses can be myelosuppressive and cause pancytopenia, which occasionally could be life-threatening. So it's important to modify the dose for patients who are on CYP3A4 inhibitors, which are some of the agents listed here, and also on patients with advanced kidney disease with a creatinine clearance of less than 30, or if they have a Child-Pugh class C cirrhosis or equivalent, to decrease the dose listed here. So almost more than half the dose reduction for patients with these modifications. And after, if colchicine, is not indicated or is contraindicated for whatever reason, then we have our NSAIDs. And you may ask, which NSAID would work the best? And essentially, there's no difference between all of them at the right doses, of course. So trials have shown there's no difference in the efficacy of different NSAIDs at their appropriate doses. So, ibuprofen 200 obviously is not going to cut it. So higher doses of ibuprofen would be needed to appropriately treat the flare. And the next question we might ask, okay, when do we use NSAIDs? And generally, it's reserved for patients who are younger than usually 60 years old, who have no kidney or cardiovascular comorbidities, who have no active GI disease. And it's most effective, again, if treated within the first 48 hours of onset symptom. And this goes along with all the other medications for gout as well. Okay, and we moved on from the NSAIDs. We have now reached the oral glucocorticoids. For oral glucocorticoids, usually we use a moderate dose steroid, such as 40 milligrams daily until the flare resolves. And then you can follow it by a taper of 7 to 10 days, although usually it's not really, required, but just for safety, you can. Shorter courses can be treated again. If we treat the gout flare as soon as the onset of symptoms, we can avoid long-term use of steroids in these patients. And randomized controlled trials have been done to compare NSAIDs with glucocorticoids, and glucocorticoids are at least as effective as NSAIDs and may be associated with fewer side effects. So I love using glucocorticoids more than sometimes NSAIDs, especially in the older population with multiple comorbidities, or if you don't have any labs on hand. So yeah. And so, we do have special circumstances where it gets a little bit tricky on how to manage these patients. For example, patients on anticoagulation. Usually we would resort to colchicine if possible. It does not have any effect on blood clotting whatsoever, so it's relatively safe. And if colchicine is contraindicated, then we would go for glucocorticoids. If glucocorticoids are contraindicated, then we would recommend intra-articular injections with steroids. And then the reason why this is now not as, top list is because, with anticoagulation, there's a concern for possible bleed or hemarthrosis, although usually, again, low risk. I feel very comfortable with injecting patients even on anticoagulation. So, but recommendations are to kind of keep it if other options are not feasible. If all options are contraindicated, you could consider IL-1 inhibitors such as anakinra. And for end-stage renal patients, who do have, frequent gout flares as well, oral or intra-articular glucocorticoids are first line. And if glucocorticoids are contraindicated, then oral NSAIDs are recommended. Colchicine can be given, and I have given patients with end-stage renal disease, but again, at a very, very low dose, maybe like once every 3 days, 4 days of half the tablet of colchicine, with close monitoring, of course. And like I mentioned before, if refractory disease, all the options above do not treat the gout flare, then we pursue with the IL-1 inhibitors. Just recently in August of 2023, the FDA approved canakinumab, which is the longer-acting IL-1 inhibitor for treatment of acute gout flares. The Europeans have been using it for a while. We just got the FDA approval just this year. So now we have our patient, he has an acute gout flare, and what do we give him? He does have this CKD with a stage 3A kidney function or kidney function. And so for this patient, colchicine will be a great choice to start him for his acute gout flare. Injection would also, of course, been more preferable, but the patient actually refused it. So if no injection, I would have picked colchicine for this patient. And so do these guidelines. So these guidelines recommend colchicine, NSAIDs, or glucocorticoids, either IM, oral, IM, IV, or intra-articular as a first line recommendation for treatment of acute gout flare over the IL-1 inhibitors. And even in the hospital setting, if patients are NPO with an acute gout flare, it's better to give IM, IV, or intra-articular steroids over the IL-1 inhibitors. All right, so we figured out what to give this patient for his acute gout flare. He's going to be started on colchicine. Now, does this patient need urate-lowering therapy to prevent recurrent attacks? So regarding this, what are the indications to start a patient on urate-lowering therapy? And usually, there's 3 main recommendations or indications to start urate-lowering therapy. 1, if a patient has 2 or more attacks within 1 year, which this patient has. 2, if a patient has any joint erosion or abnormality that is attributable to gout. Or 3, if a patient has 1 or more subcutaneous tophi. So those are the indications to start urate-lowering therapy. The guidelines do not recommend to start urate-lowering therapy for someone who's only had 1 acute gout flare unless they have a chronic kidney disease, or if they have a history of urolithiasis, or if they have evidence of serum uric acid greater than 9, and that's a conditional recommendation. The big one here, which I used to see all the time, patients being treated for asymptomatic hyperuricemia with urate-lowering therapy, and at this point, it is conditionally recommended against to start urate-lowering therapy with asymptomatic hyperuricemia, which essentially means just high serum uric acid levels with no history of gout and no tophi. So no urate-lowering therapy on these patients. All right, so we have the therapy. We know the patient also deserves some urate-lowering therapy. Which one should we start and when should we start it would be the next question to ask. And these 2020 guidelines recommend that for patients starting on urate-lowering therapy, the first line recommendation, first choice is allopurinol over all other medications, even in patients with CKD greater than 3. There was a concern initially with, even with providers with allopurinol and CKD, but the thought process here is if we start low and go slow in terms of uptitration of allopurinol, patients do really well, and it's very effective in treating and lowering serum uric acid to goal. So if a patient does have CKD3, again, recommend allopurinol and or febuxostat, so your xanthine oxidase inhibitors over probenecid, which should be contraindicated or very carefully used with those patients. And the other thing with a urate-lowering therapy for people starting on such medications, it is recommended to start prophylactic anti-inflammatories, such as same treatments for acute gout flare, so such as NSAIDs, colchicine, steroids, depending on the patient's comorbidities and other age and such. And so recommended to start anti-inflammatory prophylaxis for at least 3 to 6 months. And when should we start this urate-lowering therapy? The guidelines recommend to start at the onset of the acute gout flare that you're currently treating. So previously we used to wait until the gout flare resolved, and then we would start the urate lowering therapy. But now they recommend to start it at the onset of at the same time that you're treating the flare. And it's strongly recommended. It's the only strong recommendation against pegloticase, which is it's a pegylated xanthine oxidase inhibitor-ish medication. It's IV. It's every 2 weeks, and it is not recommended for first line. It is for patients with refractory gout who have so much tophi that allopurinol or febuxostat are just not able to control. All right, so that's gout. Moving on to our second case, we have a 76-year-old male, history of gout, arthritis, hypertension, presenting to clinic for a 4-week history of sudden onset of bilateral shoulder, hip, leg pain. The pain is very debilitating. He could barely walk. It's worse in the mornings and improves a little throughout the day. He has severe morning stiffness lasting more than 3 hours. For pain, he takes ibuprofen 600 milligrams TID, which helps for a few hours, but then the pain just returns. Warm baths, showers usually help with the stiffness. He also has this left-handed swelling and pain ongoing for 2 to 3 weeks. He denies any headaches, jaw claudication, changes in his vision. He denies any weight loss, fevers, or chills. Medical history is really not much significant in pertaining to this case. And physical exams show that he had this left hand diffuse edema with synovitis of his second, third MCPs and the second and third PIPs. He has left wrist synovitis, also has bilateral shoulders with significant limited range of motion due to pain, positive NIRS, positive painful arc, and he had a negative drop arm test. This is an illustration of what his hand essentially looked like. Oh, and here's the secret code for this presentation for the CME credit. It's prednisone. All right. Case 2, we are continuing. So his labs for his visit showed essentially everything was within normal limits, except for exceptionally high level of CRP at 99 and an ESR of 51. His vitamin D was normal. RFCCP was negative. He had an MRI done by his PCP, before, prior to seeing me, and he had partial thickness articular surface tear of the supraspinatus tendon. He had moderate amount of fluid expanding the subcoracoid bursa, and he had small fluid in the subacromial bursa as well. So this patient has a classic presentation of polymyalgia rheumatica, also known as PMR. So what is PMR? PMR is this inflammatory rheumatic condition that is characterized clinically, and patients complain about this aching, morning stiffness in the shoulders, neck, and hip girdle area. It's relatively common, and it's second common to rheumatoid arthritis as a rheumatic disease in adults. The likelihoods ratio of developing PMR is higher in women compared to men. And it's almost exclusively a disease of older adults in ages 50 or greater, with the prevalence increasing as you age. Peak incidence usually between 70 to 80 years old. Unfortunately, nobody knows the cause of PMR. What causes it? There must be something in the aging process that triggers the onset, because there's no other kind of connecting, pathologies that, can say where this PMR presented from. And one important thing to kind of keep in mind with polymyalgia rheumatica, it implies a myopathic process with the myalgia part in there. However, the muscle in PMR is absolutely normal. There is no abnormality on histopathological examination. So it is not a muscle process. It is a proximal, articular, and periarticular process involving bursas and tendons. Here is an illustration of a patient with PMR, and I sometimes show this to my patients when I kind of want to gauge if this is how they're really feeling, and almost always their eyes just pop open saying, yes, this is me. This is how I feel. And so as you can see, they usually with PMR, it's an acute onset. It almost happens overnight, although you will get your few occasional patients that have a slower onset of symptoms. It's this symmetrical aching stiffness in the shoulders, hip, and neck area, always worse in the mornings, which is a hallmark of synovitis in all our inflammatory arthritises, and morning stiffness, severe. These patients often are so stiff to move, takes them hours, if that, to actually feel normal. And almost the morning stiffness is considered invariable, meaning if they don't complain about morning stiffness, we should probably think about an alternative diagnosis. And of course, they can also have systemic signs and symptoms as well. What are the lab findings? Usually, unfortunately, we don't have any antibody profile to kind of help figure out what's going on. We do get inflammatory markers that are elevated almost always. ESR is always elevated, CRP nearly always elevated. Other kind of supportive labs, we could get normocytic anemia. Usually, these patients are rheumatoid factor and CCP negative. If positive, then we consider maybe an alternate diagnosis, such as late onset RA. But also we need to keep in mind that older patients have about 10% risk or 10% chance of having positive rheumatoid factor in their blood without any significance. But this rheumatoid factor is usually low titer. So something to kind of keep in mind. So all patients with PMR should be screened for GCA at onset, at initial presentation and subsequent visits. No one really knows, and sorry, just to kind of go back with GCA, GCA is giant cell arteritis, which is a vast type of vasculitis that affects the major aorta and its major branches, and also involves some of the blood vessels in the external cranial system feeding into the eyes, like the temporal artery. So it's important to screen for GCA. And usually these patients, the questions I will ask is, do they have any headaches? And the salient feature with these headaches is it's a new onset headache. It's a different headache that they've ever experienced in the past. It's not just your regular migraine or chronic headaches that patients experience. Number two, I ask for jaw claudication, and I ask in a way of, it's not just when you open your jaw, does it hurt? It's more about this claudication. So it's this mandibular pain and fatigue that these patients experience with constant chewing, and it resolves when the jaw rests. So that's the second question I ask for. And third questions, I ask for any vision changes. Sometimes people have kind of temporary vision loss with giant cell arteritis. So it's very important to screen. And about 10% of patients with PMR will have GCA as well. So it is important to screen these patients. So what is the treatment for polymyalgia rheumatica? This, debilitating, painful disease process. And unfortunately, we haven't had much headway into treatment aside from the glucocorticoids that we use, the prednisone that we use. Fortunately, it's low dose prednisone that these patients are on. The unfortunate part is that they're on these medications for a long time, at least 1 to 2 years, if not longer. And we start these medications until they feel better and slowly taper down, of course, with routine blood monitoring. For my patients, I usually start them anywhere for 15 to 20 milligrams daily of prednisone upon presentation. The dose can be modified, of course, depending on the patient's weight, how severe their symptoms are, their comorbidities, such as diabetes, hypertension. If there's no significant improvement with 15, I always bump them up to 20. The 20 can also be split to 10 milligrams in the morning, 10 milligrams in the evening to help with the efficacy of prednisone. The response is quick. Patients usually describe this significant amount of improvement in their symptoms, even just with 1 dose of prednisone, which in and of itself is diagnostic for PMR, in my opinion. And within a week or so, patients will have this profound, significant improvement in their overall symptoms. So and if they don't, you might want, and you have the appropriate dose of steroids on them, you might want to reconsider the diagnosis. And so no one really has a consensus of what's the optimal taper regimen, when is it best to taper. Basically, we start the steroids, and we usually takes about a week or 2 for them to kind of feel back to their baseline, painless, hopefully, self. And once that happens, we check labs, we make sure the ESR and CRP are normal. And usually this takes about 2 to 4 weeks. And after 2 to 4 weeks, if no pain, ESR CRP is normal, then we start our gradual, slow taper. And usually, especially any doses above 10 milligrams, I keep them on at least for 2 weeks, and then remeasure their blood work, taper, and kind of move along. Again, PMR usually does run a self-limited course, but it does take a while to kind of taper down. And we have 2 groups of patients with PMR. Those that 1 to 2 years of steroid taper, they're done. The PMR has kind of left the building. Then we have those patients that are relapsing that require longer treatments. So what does it mean to relapse? So we have patients that are doing great on 10. We've come a long way. You taper them down to 7.5 milligrams, and then they flare again. So this is the relapse in PMR that is almost also common, unfortunately. So now we have to go back to 10. I always go back to the dose that they previously were able to maintain their symptoms. And then again, wait 2 to 4 weeks, make sure they have resolution of their symptoms, of course, with routine blood monitoring as well with the ESR and CRP, and then taper down again. Relapsing or recurrent disease is reported in over 50% of patients, and it's almost the rule rather than the exception that these patients will relapse. Most commonly occurs within the first 2 years of treatment and with doses that are less than 10 milligrams. And unfortunately, these patients will require longer courses of steroids. Now, is there a role for glucocorticoid sparing therapies? And like I said, we haven't had much advances up until this year. We did have a new FDA drug that has been approved for PMR, which is amazing. But prior to this, we had methotrexate that we use also in a lot of our other rheumatology diseases. But the data on methotrexate and PMR is a little bit mixed. But in general, there are favorable results. And I will start these patients on methotrexate if I feel like, they keep relapsing with subsequent tapers of prednisone. Usually with methotrexate, the goal is when we start them on methotrexate, we'll be able to taper off the prednisone without them relapsing. And they have seen that, with methotrexate on board, there's a favorable result with having lesser cumulative glucocorticoid doses. The relapse rates are less, and the time to discontinuation of steroids is significantly less. Nobody knows why, but the dose that's used for methotrexate in PMR is significantly less than the dose we use for other rheumatic diseases like rheumatoid arthritis, psoriatic arthritis, or psoriasis, or whatnot. And no one really knows why. I don't know why, but I will sometimes increase the methotrexate too if that's all I have to use. And I will go up to the standard contemporary doses that we use for our other conditions. Our medications, we have IL-6 inhibitors, and the new one is sarilumab, which was again FDA approved for patients who cannot tolerate glucocorticoid taper. Tocilizumab as well, which is an IL-6 inhibitor, which has been approved for GCA, but not for PMR, but it's very promising. There have been phase 2 trials that have showed good results in terms of decreasing relapse rates and cumulative glucocorticoid doses and such. Unfortunately, TNF inhibitors do not help with PMR whatsoever, so we don't use them. Here's a study on sarilumab that they did on the Sapphire trial for patients who had relapsing disease of PMR. And the biggest thing here is that they had a higher sustained remission rate in the sarilumab group, which was 3 times higher than the placebo group. The placebo group just received a prednisone taper. And they were less likely, those in the sarilumab group were less likely to relapse once remission was achieved with a hazard ratio of 0.56. And the cumulative glucocorticoid dose was significantly less in the sarilumab group compared to the placebo group, and 777 versus 2,000 milligrams, which I think is profound. So this patient of ours was diagnosed with PMR. He was started on prednisone 20 milligrams. He was doing great. Everything kind of resolved within the first few days. His ESR, CRP were normal. So we started the prednisone taper. Then sometime of 2-3 months later, he kept relapsing, requiring higher doses of steroids to kind of keep his SED rate down and also to help control his symptoms. So that's when we started oral methotrexate on him, increased to 10 milligrams weekly with adequate response. Unfortunately, we hit another bump road a few months later where while on methotrexate, we just couldn't get below prednisone 7.5 milligrams without his pain becoming severe again. So we started tocilizumab on him, the IL-6 inhibitor that we just talked about, and he had significant improvement of his symptoms and normalization of the ESR CRP. So right now our patients on prednisone 4 milligrams, we were able to get over that hump. Tocilizumab every 2 weeks, and also methotrexate I kept on board as well for now. And he has no pain and normal inflammatory markers. So hopefully, he'll do fine. And then one by one, once we're able to come off prednisone one by one, we can start decreasing the methotrexate or the tocilizumab. No one really knows what to do after this point. It's almost like, you go as the patient describes their symptoms, but at least we were able to come down on the steroids and have him feel better. Moving on to our next case, we have a 65-year-old male with metastatic unresectable melanoma in his right lower extremity. He was noted to have the solid mass in his right pelvic wall, and CT guided biopsy did confirm he had metastatic melanoma. In May, he was started on clinical trial treatment of ipilimumab, nivolumab, and tocilizumab. In August, after treatment, 3 months after treatment, he was noted to have stable disease. And about 5 months after being on this immunotherapy medication, patient developed rapid onset joint pain in his hands, fingers, elbows, wrists, shoulders, and was having a lot of morning stiffness, significant amount of pain, and unable to really basically even take care of himself. That's how bad the arthritis was. So immunotherapy was subsequently stopped. That's his medical history. His exam was notable. Again, he had swelling of his MCPs with synovitis. He had bilateral synovitis, shoulders with significant limited range of motion. His labs were essentially unremarkable. No real abnormalities aside from significantly elevated ESR and CRP. His RF and CCP were also negative. This is just an example from what his arthritis looked like upon presentation. So this patient has, again, a classical case of this immune checkpoint inhibitor related inflammatory arthritis. And the reason I'm presenting this case is, these immune checkpoint inhibitors are becoming more and more used as part of immunotherapy for patients with cancers, and now being indicated for more different cancers, and some are listed here. And so these checkpoint inhibitors can cause a number of immune-related adverse events. So I thought it would be interesting to talk about this, how we, in a rheumatologist perspective, how do we treat these patients with this inflammatory arthritis? The first thing, just to quickly go over, how do immune checkpoint inhibitors work? And the way I like to think about it is that, our T cells are like the soldiers of our immune system. They are fierce defenders of our body. They are really good at attacking abnormal cells, cancers, bacteria, and viruses. Although they are really good at what they do, they don't attack every single invader in our body, or else our body would be in this constant state of inflammation, rash, fevers, or other immune system response. So the immune system has developed these checkpoints. And what these checkpoints do, they just put a pause on these T cells from attacking. And so this is basically in part how cancer also develops. So here, here's an illustration. We have a T cell with a PD-1 and then a tumor cell, let's say with PDL1. And this interaction here is this checkpoint PD-1 with PDL1 kind of puts a brake on the T cell, quiets it down from acting and causing, death to the cell that it's interacting with. So what these checkpoint inhibitors do, we block the interaction between the PD-PDL1 and this in turn turns on the T cell now. And this T cell is now active and able to kill the cancer cell. So what we're doing with these therapies to help treat cancer is we're supercharging the immune system to help fight the cancer. And as you can imagine, now we have these T cells that are kind of unhinged. They're able to, work and, for our benefit to help fight the cancer, but they can also attack our innocent bystander organs that are of nothing to do with the cancer. So here are where all the itises come in. We could get pneumonitis, thyroiditis, colitis, hepatitis, you name it. Almost any organ is vulnerable to get, attacked or, adversely affected from these medications. In rheumatology, for rheumatologic and musculoskeletal complications are not considered as common, fortunately, but they do occur. Of them all, inflammatory arthritis is the most common, but people can also develop a salivary gland dysfunction such as Sjogren's, myositis, vasculitis, and some diagnosis is usually just made clinically. There's no real again, lab finding or imaging finding that will discern what's what. And most patients, again, are RF and CCP negative. And with these inflammatory immune checkpoint inhibitor related inflammatory arthritises, there's a grading system. And this grading system helps kind of group these patients into the severe with their severity of their symptoms. And it also kind of helps guide management as well. So grade 1, usually mild symptoms, 1 or 2 joints involved. Grade 2, we have a little bit more joints involved. And now patients have some limiting ADLs. Grade 3, which is they have severe pain, joint inflammation, irreversible joint damage, and they can't even take care of themselves, which is kind of like our patient. So with mild arthritis, usually we can get by with NSAIDs or low-dose steroids. If few joints are involved, and again, we can do intra-articular steroids. And I think the biggest thing also to bring out over here is that, it's in the patient's best interest to have this treatment management, with the treating oncologist, just to come up with a plan together, of course, as to what you're going to give to these patients. Because as we know, there's like this fine song and dance with the immune system that's, there to help fight the cancer, and us on the rheumatology end trying to calm down the immune system to help improve the arthritis. So I think, a good, healthy communication partnership with the oncologist is always in the best interest and helpful for the patient, of course. For grade 2 arthritis, a lot of joints, they have involvement, a lot of impairment in their function, daily function. We usually do higher doses of steroids with these patients, 40 milligrams or even 1 mg per kg. We do usually see that immune checkpoint inhibitors are held temporarily until prednisone is at least less than 20 milligrams or less. Again, it's the fine balance that we're trying to get here. And if patients who do persist and cannot wean less than 7.5 to 10 milligrams, then we recommend DMARDs, such as methotrexate, sulfasalazine, hydroxychloroquine. Severe grade 3 arthritis. These are patients that don't respond to steroids and unable to wean below 20. There have been suggestions to use TNF inhibitors, no preference in which one, but only a small number of patients actually get treated with TNF inhibitors. The reason of this is, with the TNF inhibitors or any biologics aside from the ones, the conventional synthetic DMARDs, using TNF inhibitors can kind of potentially and actually can cause progression of the cancer, which is not ideal. So they have been recently published data showing that biologic DMARDs like TNF inhibitor, IL-6 inhibitor for treatment for immune checkpoint inhibitor related arthritis was associated with more rapid control of the arthritis compared to just methotrexate alone. However, they did see that these patients treated with biologics did have a shorter time to cancer progression. The good news is with the prognosis of these inflammatory arthritises and the tumor prognosis is not adversely affected by the presence of new onset inflammatory arthritis. The tumor prognosis is not adversely affected by the treatment of the arthritis, unless I guess if you use a TNF inhibitor. Studies of patients who were on PD-1 inhibitors who developed these IRAs, the immune-related adverse events, they have having this immune-related adverse events was associated with a better outcome, which just shows that, if the immune system is able to respond to these checkpoint inhibitors and become so active that it's helping fight the cancer, then it's going to be so active as well to cause these IRAs. So it's I guess a good sign in a way, but not ideal for the patient because they are truly suffering. Arthritis may persist following the discontinuation of the immune checkpoint inhibitors and require ongoing intervention. So our patient, the immunotherapy was held. He was started on prednisone 40 milligrams with a good response. His pain returned after tapering below 20. So that's when we decided to start him on methotrexate and hydroxychloroquine. Prednisone was then eventually able to taper down to 5. And currently he remains on methotrexate 25 milligrams weekly, hydroxychloroquine, and prednisone 5 milligrams daily. He does get occasional flares here and there. Despite the immunotherapy being, discontinued, which we just treat with injections, which seem to be effective. And the last case I will be discussing is is a patient that I saw, young female with history of juvenile onset dermatomyositis, and she came to me as a new patient. So she was initially diagnosed at age 12 in the Bay Area. She just had the rash, this pruritic erythematous rash on her hands and on her eyes. She had no muscle involved and never has any muscle involvement. She's been treated previously with prednisone and a few courses of IVIG. Last infusion was about 4 months ago. She's currently on azathioprine, 100 milligrams, and hydroxychloroquine, 200 milligrams. She moved to LA 1 month ago and is now here for evaluation. She has stable disease, no rash for the past 2 to 3 years. She has not required any prednisone during this time period either. She recently found that she's pregnant, and this is her first baby, and she's 14 weeks pregnant. She's very worried about her pregnancy, her baby, her postpartum, mainly because of her underlying autoimmune condition and the medication she is taking for her dermatomyositis. So we have this beautiful guideline that's been published recently by the American College of Rheumatology on the management of reproductive health in rheumatic and musculoskeletal diseases. It's just nice to have these guidelines that have been developed kind of in this evidence-based manner with expert panel patients, and even patients have been expert practitioners and patients have also been involved in helping with these guidelines as well. So unfortunately, all of these recommendations that we see are more conditional recommendations. However, this just shows just the limited data that we have on this matter and the lack of, randomized control trials and stuff like that. So, but it's really good to have these tables, these graphs to help guide us when we encounter patients with rheumatic diseases. Just gonna move on to this one. So challenges in reproductive health in patients with rheumatic musculoskeletal diseases. The biggest thing is, not all medications are safe for preconception in men and women during pregnancy and lactation. And it's hard to avoid use of medications in patients with rheumatic and musculoskeletal diseases. Unfortunately, patients who do have uncontrolled systemic inflammation, like if their lupus is, flaring, it's there. That in and of itself is a predictor of poor pregnancy outcomes as well. And also, patients are vulnerable to flare postpartum. So here are some with the guideline with the recommendations of medications that are, I wouldn't say safe, but the word we use is pregnancy compatible. So we have hydroxychloroquine, sulfasalazine, colchicine, and azathioprine, which are all pretty much pregnancy compatible. Prednisone is conditionally recommended in patients, however, less than 20 milligrams, because higher doses of prednisone is associated during pregnancy is associated with preterm labor, low birth weight. However, high inflammatory disease, our active inflammatory disease is also associated with preterm labor and low birth weight. So there is no, perfect solution for all of this. The TNF inhibitors over here are conditionally recommended. However, of them all, cetralizumab is the most pregnancy compatible, given that it is pegylated form of a TNF inhibitor, and so it doesn't cross through the placenta and into the baby. These are the absolute no-nos for pregnancy that every patient on this medication should be counseled about, contraception and to avoid these medications if they do get pregnant. Methotrexate is a big-time teratogen. As we know, methotrexate is used for abortions at a much higher dose, of course. So methotrexate is usually stopped months prior to conception, and we don't recommend it, of course, during pregnancy or lactation. Leflunomide, similarly, we don't recommend. There is actual medication that provides a washout for leflunomide if a patient's pregnant while on leflunomide. Mycophenolate, again, not recommended. Cyclophosphamide, also not recommended for men and women. Cyclophosphamide actually decreases the ovarian reserve in women. So, we recommend stopping 3 months prior to conception. And also with men, it can cause oligospermia. However, if we do withdraw the medication, men are able to have ongoing spermatogenesis. And thalidomide, we all know, is notorious for phocomelia with the abnormal limbs in patients, in babies that are exposed to thalidomide. So absolute no. And I think 2 or 3 contraceptions are recommended prior to getting on board with thalidomide. One more thing I wanted to kind of discuss, mostly for lupus patients, as they are our younger female patients who are of childbearing age. And for lupus patients, the recommendation is to have quiescent disease at least 6 months prior to trying to conceive. And so once they're, quiescent, then we make sure they're on a pregnancy compatible medication. If not, we switch them over to a pregnancy compatible medication, see how they do, and then recommend for them to go conceive. But in the real world, this does not happen. We get patients all the time who just find out they're pregnant and on a medication that they shouldn't be on. So again, counseling is so important for these young patients. So once we have low disease activity and they're on these pregnancy compatible medications and the patient gets pregnant in the ideal world, if they have lupus, it is strongly recommended to continue with the hydroxychloroquine, especially now that, we're pretty comfortable that it is pregnancy compatible and it actually helps, decrease the rate of flares and improves the outcome of the mom and the baby as well. Low-dose aspirin, 81 milligrams, is now conditionally recommended for patients with lupus. This comes from the American College, the ACOG, and the United States Preventative Health Task Force, who recommend low-dose aspirin for patients who are of high risk for preeclampsia. And lupus patients are considered high risk. Moving on to patients with antiphospholipid antibodies, regardless if they've ever had any obstetric or thrombotic events, anybody who has antiphospholipid antibodies should be placed on a low-dose aspirin during pregnancy, again, as they are high risk for prophylaxis. If they've had any thrombotic or thrombotic or obstetric complications while having these antibodies, then it's strongly, strongly recommended to put these patients on prophylactic heparin during and after pregnancy. Lastly, regarding contraception for these patients, two things to kind of keep in mind. Estrogen containing products anywhere, any contraception that contain estrogen increase the risk for flare for lupus and antiphospholipid syndrome. Estrogen also increases risk for thrombosis in lupus and antiphospholipid antibody syndrome. So strongly recommend to use progestin only or IUD contraception in lupus patients. And the presence of antiphospholipid, even without any history of blood clots or any obstetric complications, it is contraindicated to use estrogen-containing contraception due to the potentially increased risk for thrombosis. So our patient remained on azathioprine 100 milligrams daily. Hydroxychloroquine was continued. These two medications are on the pregnancy compatible list, so we felt pretty comfortable with that. Fortunately, her pregnancy has otherwise been uneventful, and patient is due at the end of the month, so maybe even now. So we'll see. And yeah, that is it. Thank you very much. Please let me know if you have any questions.